No, as I understood her, she
I
gets
think
now
it must be now.
she thinks it must be now. Do you see her?
Just tell me when I'm live.
She wants to know when she is live. She wants to know it. She is live now? Yeah, she is live. Okay, she can start.
Hello,
Okay,
hello.
okay.
I'm happy. I do have internet at least. So, good morning, good afternoon, good evening, my dear friends, my dear colleagues. So, welcome to this webinar. Well, someone is cooking these days, someone is drinking, dancing, checking corona news, of course. But let's do some dentistry. Let's talk about Dentin Graft. It wasn't easy at all to prepare for this webinar. Mark Bishara guided me. You can see his instructions like hit the bottom left, and then me like wild with my mouse over the screen, and then Mark bottom left corner. And then at the end, I already thought he's recording video of my screen. Of course, he was in my team viewer, and his comment at the end, listen, we can't be good at everything. This is okay. You know how I was when he says you are okay. So I changed 5 outfits for tonight. My first, I thought I'm going to have a dark black background, so a dark shirt would be nice. But my husband told me it looks like one of these living pictures from Harry Potter when I'm moving my head. So I tried with a white shirt, and he said it looks like Cruella de Vil. Then another white shirt, he said it's like grandma. So pink Jornada shirt, it wasn't good. And then t-shirt, our outfit that we now have for the weeks. It's really unbelievable. It is 4 weeks ago. This amazing Dental XP Symposium in Atlanta. We enjoyed our time so much. I gave the lecture of my time. We had so much fun. The Maurice Lama and the Atlanta team were great hosts, really amazing. In between preparing Divas in Dentistry in October in Dubrovnik in Croatia. But now we are all in coronavirus, and if it wouldn't be enough, earthquake with epicenter in Zagreb, capital of Croatia, few days ago. Normally, when I give a lecture about Dentin Graft, I give a scientific background, and then I talk about clinical value, showing my cases. But today, more than usually, I'm going to focus on autologous and inexpensive. Because, when they come back, we will have financial deficit. Not only we, dentists, but our patients. They are going to be sensitized. They are going to ask about materials that we are placing. They would like to know origin, and they won't have money. And so we are going to be forced to look for alternatives for the materials that are not that expensive. And one of them is dentin autograft. So immediately on begin, I want to disclaim that I don't have any financial interest not doing this webinar. What connects me with Mark Bishara is not only passion for dentistry, and that I admire this guy and everything that he is doing on Canadian implant dentistry and in general. What connects us is Jason, this amazing little boy, and Mark Bishara does know it, and he misuses Jason to tease me. And I became friends with family Binderman. Professor Binderman, he is the man who came with the idea to grind the teeth, mineralized, non-demineralized teeth, and to produced a particulate dentin graft. We became friends, really friends, but I don't have any financial interest. I think it is important to know already for begin. So, let's start with dentin graft. Why dentin graft? Because the structure, both chemical and biological structure of dentin graft and the alveolar bone are very similar. Of course, dentin has less organic material, 20% for dentin, and for alveolar bone 25%, and it has more anorganic material, 70% for dentin and 60% for alveolar bone. And you are going to see why is it good, why is it better for dentin to have more mineralized structure than alveolar bone, why it performs better than alveolar bone. And then biological structure. All growth factors that can be found in alveolar bone can be found in dentin graft. Bone morphogenic protein, insulin-like growth factor, transforming growth factor. All these factors that play a major role in promoting bone remodeling, they can be found. So, I have done research, and my research is always reading the literature. This is what I'm good in. And literature about dentin, wow, it was really adventure. Very, very interesting. But then I should have come to this machine and to organize everything. And then I gave this task to my students. And you know, the students, the residents, young people, they are a little bit lazy. And they came to me and said, you know, it's somehow complicated. We cannot find a dealer for this machine for Croatia, and it seems to be very expensive. And this process of demineralization, it takes rather a long time. It doesn't seem very practical. But look, we have found something different, something similar. It is like a coffee mill machine. It is a machine that grind the teeth, and at the end we do have non-demineralized dentin graft. So I was a little bit skeptic, but then Rocco Melle, he comes from veterinary. He posted nice cases, amazing cases with dentin graft, and he wrote me emails about it, and he was very, very satisfied with material. So I exchanged some emails with Cometa Bio CEO, with Amit Binderman, and when he couldn't cope with me anymore, he connected me with Professor Binderman, Itzhak Binderman, who is behind this dentin grafting material. And poor guy answered a lot of my mails, and so I decided to start to utilize mineralized dentin graft. Or there is actually a better term for it, non-demineralized autogenous tooth-derived graft, but it is rather a little bit long. This is Kotsakis came with this idea. So I was pretty sure, because this material is mineralized, that it is going to keep the rich volume. And this is also what animal studies, Professor Guirado has done these studies, has shown, and also rather a small pilot study from Spain, only 9 sockets, but showing nice rich volume maintenance. Since I've been doing so many surgeries, I had a huge amount of CBCTs before tooth extraction and 4 months after socket grafting with dentin graft. So I decided to do CBCT evaluation. I sent the CBCTs to independent researcher in Cairo. He is in 3D vision studio. This is from Rami Gamil, dental expert. Wasim Ibrahim is his name, and he has done all measurements, and he was very correct. What we have found out? We have found out that rich maintenance is fantastic. utilizing dentin autograft. One paper is already published. Later on, I'm going to put the link into the comments. It's published 4 weeks ago in Materials. And we have chosen only 58 sockets for this part 1. Only sockets where the buccal bone height is not less than 2 millimeter compared to the palatal bone wall, and independently on the palatal bone wall. Was socket type 1 and not more than 2 millimeter deficiency in the buccal bone wall height. On this CBCT from the patient, you can see something very, very interesting. What is interesting? There is almost no buccal bone resorption, and we gained the palatal bone wall height. We gained. On this CBCT, this dentin graft, you can say immediately it is a grafted site. Is it a real bone? But wait a little bit. We are going to show the histology and re-entries. And notice the procedure, very simple procedure. Theta taken out, flapless, dentin grafting material is placed into the sockets, and to contain this material, PRF membranes are placed on the top to close the sockets. This graphic is showing what happened with average socket. The average socket initially is in green, before tooth extraction. And the average socket 4 months after dentin grafting is shown in color blue. And the third image is showing superimposition, before and after. There is very little buccal bone resorption, measured 1 millimeter. From the highest ridge point on the buccale, there was 0.8 millimeter buccal bone reduction in the horizontally. And there is very, very little, even compared to xenograft that is known to maintain perfect ridge dimensions. I'm not talking about the bone quality, but it is really amazing. There is no grafting material that can maintain completely the ridge dimensions. There is no grafting material that prevents buccal bundle bone resorption. It's only partial extraction therapy, socket shield, root submergence procedure that maintain the ridge dimensions almost completely. And again, interesting, on the palatal, we gained in average about 2% of the height, and on the buccal, we gained in average 6% on the height. So Professor Rodrigo Neiva used to say in his lectures that it's about the time that we stop talking just about the volume dimension maintenance and volume changes. We should look into bone quality, and I cannot agree more. We really want to have a vital bone for our implants. But nevertheless, it's very important to have a nice ridge dimension. I mean, aesthetic area, in average, 2% gain in the buccal bone height, only less than 1 millimeter ridge reduction in the horizontally. This is great. Okay, I've done some histologies, and these histologies are in accordance with already published literature, showing intimate contact between dentin graft and surrounding vital bone. There is no fibrous encapsulation. There is intimate contact, there is ankylosis, and this is not surprising. And in this slide, I used to mention Narayan Venkatram, who forced me to prove that this is really a vital bone. So I've done immune histochemistry, and this immune histochemistry is done with Osterix antibodies, showing positive osteoblasts and pre-osteoblasts, showing that this is really a vital bone that surrounds dentin particles. Just to show you, some of CBCTs are used to check each side. This is what we get. Again here, the gain in the palatal bone height. Most of the teeth are periodontal disease teeth, because if socket shield procedure is possible, I prefer to do partial extraction therapy. But it's not always possible. And instead, to discard the teeth, we grind them and put them into the sockets. And patients really love it. They love it. So one can say, okay, there is a vital bone surrounding dental particles, but look, this is 4 months after the grafting, and this dentin particle is rather big. Is it going to resorb ever? Yes, it is. This is what last year 2 researcher teams have shown independently from each other. You know, a lot of these names you are familiar with: Ziv Mazol, Bob Horowitz, Kotsakis, Nelson Pinto, Andrade. They have shown healing dynamics following socket grafting with mineralized, or we can say non-demineralized dentin graft. What are they showing? They have shown what we expected. I think these images are self-explaining. 2 months after the grafting, there are a lot of dentin particles and very little lamellar bone, woven bone. But 7 months after the grafting, a lot of vital bone and very, very few dentin particles. Yes, this material does resorb, and it has really nice balance thanks to this mineralized structure between bone resorption and new bone building. This beautiful image is a teaser to my next paper that it's hopefully going to be published, written together with Kotsakis. Because it's still not published, I cannot tell all the secrets, but it's going to be very interesting, very, very nice what we have found. So, a few years ago, a very nice study was published about partially demineralized dentin. The authors have done really nice comparison. How does demineralized dentin performed compared to mineralized and partially demineralized dentin? And the truth is always in between. The best features were shown for partially demineralized dentin. So, maybe for 2 years, I think it's 2 years, Maya is listening, he can say, is it 2 years? I used to use partially demineralized dentin, and I love this protocol from Cometa Bio because using EDTA for 2 minutes, only the superficial layer of dentin particles is demineralized. What does it mean? It means that the dental tubuli are open, collagen is exposed, and the growth factors are released immediately and can do all osteogenic story that they are supposed to do. And there is a substance, there is a scaffold inside mineralized dentin that maintains the volume for the long time until the new bone is built. So, let's summarize. Between dentin particles and newly formed bone, there is ankylosis, the natural fusion. Dentin is autologous tissue. It means we don't need to wait 7, 8, 9, 10 months before we place implants. I usually wait in upper jaw 4 months and low jaw 3 months, although the times can be shortened. Dentin can be beautifully applied for the gap filling, for post-extraction immediately placed implants. So we can proceed faster. It has osteogenic and osteoconductive properties, and it has this nice balance between resorption and bone new building. It is the only one autogenous material that doesn't require a secondary harvesting site. It doesn't hurt at all, and patients, they really appreciate it. They love the idea. They are excited when I say them, we are going to reuse your own team to produce the best grafting material. And it has good handling, mixed just with blood or with IPRF. Sticky dentin can be done very nice. I won't show receipts now how to make sticky dentin. Amit and Maya are going to put it into the comments, and you can find everything on Cometa Bio websites. This is again Maya Lukic, my assistant. She's in charge of dentin. And I think she came with some secrets to produce sticky dentin before anyone other. And a few days ago, there was a nice webinar on, I think it was Small Dentin Grafting user group from colleague Gurin, showing, presenting about the sticky tooth. This is why dentin graft is in the moment so interesting, more interesting than ever. There is no fear of disease transmission. There is no immunogenic response. For this reason, there is beautiful healing. I know so many colleagues, so many friends utilizing this dentin grafting material, and we are very honest with each other. We don't see complications. We don't see disturbed healing. Nothing. It's always nice. If, then always because the protocol is not followed. Some colleagues used to message me, two of them, wow, look, it wasn't good, I didn't like it. I connected them with Cometa Bio, and then they interfered and found out that protocol was not followed. And this grafting material is more economical than most grafts on the market. This is one case, absolutely not fancy case. And I don't have a perfect case documentation because I never thought I'm going to show this case because it's not a fancy case. The patient, this is done 3 years or maybe longer ago. She had financial problems, and she said, I hate idea having a denture. I would love to have something that is fixed. I know I need implants, but in the moment I don't have money for the implants. I think in 1 or 2 years I'm going to have enough money, I'm going to sell something, and then I can afford implants. And I'm very, very happy that I decided to utilize hair extracted teeth to fill the sockets. Very easy procedure. PRF membranes just to contain the graft. This is how it looks like 1 week after the procedure was done, and this is how the ridge looks like. The patient really came back 2 years after the procedure was done. Very nice ridge. What do we see usually 2 years after the patient had the denture? Mucosa supported denture. And this is how this ridge looks like. It's bone. It is a real bone. We made a real bone. So utilizing denser drills, always denser, and denser is really great also for dentin grafted sites, depending on the health. We use it in clockwise or counterclockwise direction, but this is in another story, in another lecture. The defect that you see for the left central incisor, it is after the sample harvesting for histology. I've done a few histologies, So implants were placed, the buccal roll flaps were done to improve soft tissue, and look how it looks like after the healing. How much did it cost? 60 euros for this patient. Independently, is it one side or upper jaw and lower jaw? Of course, the machine, non-expensive, but don't ask me this, but for one patient, the sterile chamber and all chemistry that we need is about 60 euros. So, and I think you agree with me, it's really shame to discard perfectly reusable patient's tissue and then use artificial bone or cadaver bone or bone of animal origin. And I see also in my groups, and I do have some of them, that this question is rising again because everyone is now scared a little bit. I don't want to make a panic now, really. It is not what I intend with this webinar. But do you remember 15 years ago, the prions, there was a big action from the World Health Organization, and we talked a lot about it. Our patients had to sign that they know that it's not excluded, that some disease can be transmitted. It was the story about the prions after 3 patients got Creutzfeldt-Jacobs disease after the blood transfusion. It is it was 15 years ago, and when we look not only in dentistry, but for example, orthopedic surgery or oculofacial plastic surgery, the recommendation is to avoid the use of xenografts enterally and to limit the use of human allografts. Maybe the grafting materials are safe for the prions, but the next new virus or unknown pathogen is always on the horizon. This paper was published in 2016. Unfortunately, I cannot point out, but after reviewing the literature and the actual situation, the authors in a very serious journal recommended to be very cautious with utilization of xenografts. So now you have to see the underlying again, because I rushed too much. Here we are. So more fancy case. It is the patient was finished. I'm going to show more fresh cases. I'll try not to repeat the cases that you have already seen. The left central incisor doesn't look that bad, but look at CBCT. The buccal bone wall is missing entirely and the huge periapical area. The tooth is vital. We utilized non-vital. I thought it doesn't have any root canal treatment. We utilized the wisdom tooth, proceeded into the dentin graft, icon-shaped membrane, grafting dentin autograft to fill the socket, and the simple PRF membranes over it. Normally, for the buccal bone wall missing sockets for socket type 2 and type 3, I prefer Maivan technique, but this patient couldn't afford at this time point any post-operative morbidity. It was very important for her not to get a swelling and to be able to work and to present herself. So very, very simple upper wisdom tooth was taken out, the socket was grafted, and PRF membrane all on the top of it. So when the patient came back after 4 months, this is CBCT, so I was able to place an implant and to enhance the buccal soft tissue volume utilizing a connective tissue graft, and this is how it looks like after the treatment was finished. Very easy procedure. For this patient, this is a failing implant for the right central incisor. I took implant out. You guess it wasn't my implant. Otherwise, I would have do connective tissue grafts in order to prolong the prognosis for this implant. No, I'm just joking. The patient, she had 2 years. She came to me in this state of mind after 2 years cleaning of this implant and taking antibiotics. She really wanted only to get rid of this implant. The buccal bone wall, you guess, is completely missing. So the implant was taken out with this BTI set, and now Maivan technique was utilized. Maivan technique is a simultaneous hard and soft tissue augmentation for sockets type 2 and sockets type 3. There are 2 lectures to this topic on Dental XP, my lectures, and on my Facebook you can find a lot of Maivan cases and also 2 papers published to this topic. And this time, instead of combining autogenous bone and xenograft for the superficial layer, simple dentin autograft was used. So the socket was filled, compacted with dentin grafting material, and socket orificium is covered with the pedicle connective tissue graft. This is how it looks like when the patient came for the implant placement. The CBCT in the left corner is not showing initial situation. Initial situation was failing implant. I don't have this CBCT on my hard disk, and in the moment I cannot go to my clinic because I am closed on my island. But the CBCT of adjacent central incisor I put here in order to show you the thin biotype that the patient has. So implant was placed, and this is after the treatment was finished few weeks ago. Before and after. So dentin can be used for socket preservation, for defect augmentation, but also for the horizontal and vertical ridge augmentation. In this case, it's utilized for veneer grafting. Look at this very narrow ridge and the horizontal ridge resorption, low smile line for this patient. Luckily, we do have a denser burst, so I could expand the bone in order to place the implants. And now the implants, they are inside the bone envelope. And this is a huge difference. If we do have a titanium and place our grafting material on top of it, or we do have a bone to place our grafting material on top of it. And again, the patient had a nice wisdom tooth, ground, sticky bone was done, and veneer grafting. Collagen membranes in place, something like lasso technique, not exactly. And in most of my cases, I place connective tissue graft additionally. This is immediately after the surgery, healing, implant uncovering. Pay attention on papillas between canines and lateral incisors. This is a modified Palace technique. It means a small semilunar flaps from palatal were flipped in order to build a papilla between canines and the lateral incisors. And this is how it looks like after the healing. And this is how it looks like after the definitive prosthesis bridge delivery. Great material for the defects. Here, the left central incisor and lateral incisor are failing. Not only failing, look, there is no bone on the buccally, nothing. Just a little bit of the interdental bone only on the palatal and absolutely no bone on the buccally. Simply dentin grafting material, the sockets filled, covered with PRF membranes. And look at this keratinized tissue. Look at this rich volume. Isn't it amazing? No primary closure, no mucogingival junction displacement, simple open healing. So for the left central incisor, I could place an implant in flapless manner, and here I open the ridge in order to see how this ridge looks like. It's 4 months after the grafting. It's born. This is what we gained. Dentin autograft and its application for Curie technique. Very narrow ridge, low jaw, CBCT showing very narrow ridge. Meanwhile, this premolar was extracted, and now the second molar should be extracted, and luckily there is a wisdom tooth. So, yes, I harvested bone plate from linea obliqua for Curie technique, but the wisdom tooth was proceed into the dentin graft, utilized to graft the socket of the second molar and to fill the gap very tight for the Curie technique. Immediately after the surgery and then the follow-up, look at this bone, look at this ridge. It is the case reopened. Maya can witness it just before Corona, and again comparison. Amazing. And patient didn't suffer a lot. I know she's my neighbor. Here, Denza bursts in clockwise manner to prepare the implant site. So now I think and I hope there are some questions, and I thought like this, I'm going to answer the questions if there are some, maybe for 5 minutes, and then you can choose among these cases which one do you want me to show. I have chosen 11 cases just to fit with my last Dental XP lecture, where I have shown 11 central lateral incisor cases managed with partial extraction therapy. Vlado, are there any questions? Are there any questions? So I have to read the questions. Is it mandatory to place membrane like other grafting material on dentin grafts? No, it is not mandatory. It is not mandatory. As you have already seen, I used to cover the sockets only with PRF membranes. It is, I noticed, if there are fistulas and the periosteum is damaged, in these cases I used to place a collagen membrane, but in other cases not. So let me see if I can read other questions. It's showing glare. Rado, can you open the questions to me, please? So it's very complicated. How are the teeth treated before being used for grinding? So I'm going to show a short, rather funny animation to this, and I advise you to go to Cometa Bio websites to see all these protocols, but briefly. First, mechanical cleaning. So we must remove all materials like composite or ceramic, or also the lesions, caries should be removed. we should remove periodontal ligament. Simple clinic. You can utilize whatever. You can utilize your high speed with round burr or piezo or mechanical instruments. First of all is mechanical cleaning. After, and then the tooth is dried, it comes into the machine, into the chamber, and it's ground in a few seconds. It's ground into the particles. There are two draws, and we are interested in the upper, because in the upper draw the dentin particles with size between 300 and 1200 micrometers are there, and this is the optimal size to get a nice bone regeneration. Afterward, 5 minutes into the cleanser, drying, EGTA if you want to produce a partially demineralized dentin, and then washing twice with the buffered saline solution. But Amit, I'm sure he's following this webinar. He's going to put links to the animations and videos and all instructions and guidelines. So there are some more questions. I have to read them here. How do you store extra graft if you want to use it later? So there are a few possibilities. One, the official recommendation, and I agree with this recommendation, if I have an access. First of all, think about it on time. Don't mix your dentin graft with the PRF or blood or bone or other materials because you cannot use it. But if dentin is dry and not mixed with other materials, you just put it with each dentin chamber. You get a small dish where this dentin can be put and saved. I used to give to the patient this excessive dentin material. So, but there are also patients, we are doing tooth extractions and they don't know if they are going, and maybe it is wisdom tooth, and they miss the first molar. And patients are not sure if they are going to have implant or not. So, and they are not willing to pay now for dentin processing, for sterile chamber and for this process. In these cases, we clean the tooth, dry the tooth, and give it to the patient. And say to the patient, when you come again, if you come again for implant placement, please take it with you. So, how long do you wait for re-entry for dentin graft? I wait 4 months for upper jaw and 3 months for low jaw. Do you use the enamel tool? Very interesting, very good question. So, there are a few possibilities. Just let us think together. Enamel actually doesn't resorb, or not completely. And this is a great thing for veneer grafting. It's good to have then particles that don't resorb and don't disturb for the veneer grafting. So, enamel, welcome for veneer grafting. I don't use enamel for peri-implant gaps and not for the implant side, not. But for the cysts, for the horizontal ridge augmentation, yes, enamel can be utilized. So now let me know which case do you want to see. Like low jaw, very interesting, failed implants and tuberosity composite graft, full arch, stage approach, nice case. You see, I have put nice cases on the top. And the first one, just tell me the number. 1, 2, 3, 4, 5, 6. Just write the number and Mia is going to tell me the number so I can show the case. But maybe in the time in between, I can show whatever case like something coming. Yeah, we are waiting for you.
Rita Singh number 6, Bodo Miro number 1.
Rita Singh, how does it come that I knew that you are going to be the first one? I almost called you and told I want to have Rita Singh. Okay, this is utilization of dentin autograft for the failed implant. There is implant for the central incisor and the left incisor implant. There was spontaneous exfoliation, and this is how the patient came. The implant on the right has a very little buccal bone, and look at the mucogingival junction for the lateral incisor area with the defect. When I open the site, it really looks like a xenograft with inflammatory tissue and fibrous encapsulation. I think you know the sites, also a few papers published to it. Maivan technique is done, pedicle connective tissue graft, and this fancy approach that I've learned from Michael Picos with the double tunnel. Because of this mucogingival junction displacement, I've taken care immediately at this first surgery about vestibulum and keratinized gingiva. Gingiva strip was utilized in order to enhance vestibulum and keratinized gingiva. Fortunately, there was a wisdom tooth to use to produce a dentin graft, and now you see how it looks like. The green arrow is showing the part of pedicle connective tissue graft that I left exposed. On the top you can see a gingiva strip, and this is how it looks like immediately after the surgery. Then the buccal sliding palatal flap was utilized at the time of implant placement. This is also a secret right now. It's going to be published very soon. This technique, of course, densa burrs to prepare the site. We needed more bone on the vestibular, on the buccal. The patient has a very, very thin biotype, and you know it's always very, very difficult to rebuild the bone for the patients with thin biotype. This is how it looks like. I have forgotten to say something. This is how it looks like immediately after the surgery, and very important detail, healing abutment is placed on the implant, and then the flap is closed over the implant graft, implant with healing abutment. This is guided soft tissue augmentation to gain more vertical soft tissue, published by Dr. Salama and his group. And look how it looks like afterward. Great vestibulum, mucogingival junction is on the place where it's supposed to be. This is then at the time of the implant uncoverage. This is 6 mm healing abutment, 2 mm thanks to the guided soft tissue augmentation. And this is not an ideal result, but it's pretty good. So, Vlado, you said Bodo Miro would like to see case number 1.
Yes.
Okay, let's see the last case of today. Low jaw, very interesting case because I combined here dentin autograft with the composite tuberosity graft. A composite tuberosity graft, it means that it contains the bone periosteum and connective tissue. And I used to leave also epithelium on top of it. I was very lucky that patient had such amazing tuberosity. It's not always the case. So initially you see two failing central incisor in the low jaw implants with rather big hard and soft tissue defect. So the implants were taken out and this composite tuberosity graft was utilized to rebuild this site. I wanted to fixate this graft and I didn't know better but to use a long pin, and it was absolutely enough. And all that spaces were filled with dentin autograft. Not only that spaces, but also look at the orthopantogram, premolars and molars, rather a big defects for this teeth. This is initially CBCT, look, two central incisors, implants, and then premolar and molar on the right and on the left. And look at the CBCT afterward. And I was able to place the implants, and it was all that I used in this case, nothing more. So the time to uncover the implants, here I utilize something from animal origin. This is a collagen matrix in order to improve the soft tissue. I've done so many surgeries also in the upper jaw for this patient, so I try to reduce post-operative and operative morbidity for the patient. Implant uncoverage procedure, and this is how it looks like at the end. So I think that it is about the time.
Another question?
It's about the time to finish. I'm going to answer maybe another question, and then to see. Dr. Sandeep Singh, dear Snjezana, what's your opinion about using partially demineralized dentin graft in case of peri-implantitis, where we see treat exposure and patient is not at all convinced for explantation and ready for retreatment surgery? I'm not so easy to do regenerative surgery or attempts to do regeneration for the implants with peri-implantitis. I see the defects that would support grafting material not very often. I don't see indication for the regenerative peri-implant surgery very often. I've done, of course, like everyone, for few or many cases with results like sometimes I have enough cases to show it works, but I have even more cases that show that it doesn't work. I don't think that material is here decisive. Although I have nice results with tuberosity, corticospongiosa, corticocancellous tuberosity bone blocks. And if I would choose among the materials to use them for the peri-implant defects, it would be partially demineralized dentin and corticocancellous tuberosity. But I tend, if I want to save the implant, I tend to do implantoplasty and work on keratinized gingiva and to enhance the peri-implant soft tissue volume. This is my approach. So if some more questions come, I'm going to answer them in the comments. So the entire procedure to proceed dentin grafting material takes 7 to 8 minutes, but after the teeth are cleaned. And this is the only one part that I don't like that much. I mean, Maya is doing this, but But Amit promised me really some nice solutions to do more mechanical tooth cleaning to make this procedure easier. And afterwards, the procedure looks like this. Thank you for your time, and thank you to Mia Bullion, who sent the questions per WhatsApp to my husband, who gave me the questions, and thank you, Vlado, too. So now I go offline, and I'm going to answer the questions if there are some in the comments. Bye! Stay safe, stay healthy. Mark Bishara, what would you say? You are going pretty good, but you cannot stop streaming. Now I will stop.